Hello, everybody. Welcome to the Research Roundtable, the IOCDF live stream where we discuss some of the most current and interesting research going on in the OCD research world. As always, I'm Kyle King. I'm one of your hosts. I'm, I guess, technically now a senior at Yale, studying neuroscience with a particular interest in OCD, not only because I think it's a very fascinating disorder, but also because I have it. So all the research is really relevant to me. As always, I'm joined by my co-host, John Abramowitz. John, if you want to say something about yourself.
As always, I'm John Abramowitz. I can't shake that. But no, Kyle, it's good to be here. And I'm a professor of psychology at the University of North Carolina at Chapel Hill, and I study OCD, and I also consult and work with folks who have OCD and do treatment. And I'm looking forward to our roundtable this afternoon.
Yeah. So we do have two guests today, and I just want to say that this is the first time that I've known both the guests before joining the live stream, and I did feel really cool. Before I introduce them, I have a few words that I need to say. So first, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDS online resource directory at iocdf.org/find help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please go to your local emergency room or call 911 or the 988 Suicide and Crisis Lifeline by dialing 988. Also, this is live and we have a chat function. So we really love when you guys ask questions in the chat or put little comments in there. Just know that anything you put in there will live on the internet forever. So be mindful and be respectful. We're talking about some sensitive subjects, so everyone be nice to everyone else. All right, so with that out of the way, now it's time to introduce my guests. Let's see, whose bio do I have first? Eric. So Eric Storch is a professor and Macon-Vale Presidential Endowed Chair, that was long, in the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. He serves as vice chair and head of psychology and co-directs the Obsessive Compulsive and Related Disorders program at the Baylor College of Medicine. Eric, in honor of what we were discussing before we went live, what's your favorite band?
So Britney Spears, before she, sort of went in that weird phase that she had.
That's interesting. I would not have pegged you for a Britney Spears guy.
Nah, I once had their CD, and it was all I had on this long trip from, I remember, New York City to way upstate New York, and so I really just sort of got into her. But
so would you be willing to sing a little, or?
I don't want to show my colleague Jim up. Plus it's midday, so still got to kind of get a couple drinks, which you can't do at work. It's frowned upon at Baylor.
Okay, that's a Baylor policy. Well, maybe at the conference at the karaoke night we can get into it.
It's on.
So James, our other guest, Dr. Crowley. His research focuses on psychiatric genomics and includes molecular genetics, epidemiological, and twin studies of several psychiatric disorders, including obsessive compulsive disorder, Tourette's syndrome, schizophrenia, and anorexia nervosa. Dr. Crowley earned a BS in biology from Cornell University and a PhD in pharmacology from UPenn, followed by postdoctoral work in genetics at Duke University. Jim, what's your favorite band?
I love classic rock in general, and one of the saddest moments ever was when I heard Guns N' Roses on a classic rock station. Then I realized maybe I am a little bit old.
I still listen to Guns N' Roses.
Yeah, I guess they're classic rock. Even Nirvana was on classic rock.
Yes.
Oh man, it makes me feel old.
I listen to them more than I listen to Britney Spears. That's for sure.
Good.
Hey, I've wrestled with him. So when I was a kid growing up on the Baltimore Orioles, there was a player named Terry Crowley. Who spelled his name the same way that you do, but then I've heard people refer to you as Crowley. What do you go by?
It's an Irish last name, and I should learn how people in Ireland say it. I guess that would be the way. I say Crowley, but either is fine by me.
Sorry, Jim.
No, I've heard it both ways, and now I know, and so I don't feel anxious about that anymore.
Just don't call me late for dinner. Isn't that the saying?
Don't call you Britney Spears.
Storch.
So normally on the Research Roundtable, we pick a topic and then discuss kind of the research surrounding that topic. We're going to do something a little bit different today. And we're going to focus on a particular research project, get a little bit more granular. The research project is the Latino Project. It's an acronym. It stands for the Latin American Trans Ancestry Initiative for OCD Genomics. And saying we're getting a bit more granular may be misleading because it's a massive project, as I understand it. And I'm not even going to try to attempt to explain it. But we have two guys who are leading it here. So Eric and Jim, I don't know who wants to take this first question, but at a high level, what's the deal with the Latino Project?
Yeah, Jim, you want to go?
Yeah, I'm happy to. Yeah. I would say, in a nutshell, OCD research is not diverse enough. That definitely applies to genetics because, we're working on a big paper right now, the largest OCD genetic study yet, and it's 100% European ancestry. That's a real big problem because that doesn't capture the world. I think Europeans are maybe 20% of the entire world. So, we really need to increase diversity. And that's one aim of this study, is to increase genetic diversity because, we want these results to be useful to everybody in the world, not just those who happen to be of European ancestry. And then on the clinical side, I guess, Eric, maybe share that your perspective.
Yeah. I think there are a couple of really impactful aspects to this. So one of them is, what Jim was talking about in terms of this aspect of precision medicine. So the whole notion to it is that we get better at understanding what person responds to what treatment, and then we prescribe that treatment, whether it's behavioral, whether it's pharmacological. So if your models are based on only individuals of European Caucasian ancestry, you end up perpetuating this health disparity. So this project is really all about a grassroots effort to have people who are affected with OCD who have some element of their ancestry being Latino. Doesn't have to be 100%. It can be 15, yes, that would make sense. It could be, like one of your grandparents was from Mexico. But it's really about addressing this health disparity in precision medicine. The other thing we're doing is, we've taken this opportunity in building a network representing 14 countries, 50 sites, many of whom don't have our frontline OCD treatments available to train in those. So like in a month, literally a month from today, we go down to Peru and we'll have the second ever OCD Congress of Latin America take place there, where you have individuals from all over Central South America, the US, come in and talk about OCD, its treatment, how to do exposure therapy, and so on. And so that's really a big push that we're doing on top of this genetics-based research.
Okay, so I have a couple of different lines of questioning that I want to go off of. I'll start with you, Jim, and kind of the genetics piece of all of it. So what do we know about OCD genetics as of now when we just look at the European Caucasian ancestry data? And what kind of evidence do we have from other psychiatric conditions that there's a pretty significant difference if you look at people from different cultures?
Absolutely. I guess, first of all, we know OCD has a heritable or genetic component because it runs in families. And we know from twin studies that there is, genetics are involved. And then in terms of, the findings in Europe, it's really clear that OCD is really polygenic. So that means many different genes are involved. This is not like a one gene disorder. So it's not like, say, cystic fibrosis or Huntington's disease, where it's literally one gene determines everything. Very different, probably hundreds of genes, much like other psychiatric disorders. But that's okay. We can deal with that. We need large numbers of individuals. That's one of the reasons this study is so large. We need a lot of people to help and participate. And then, in terms of other ancestries, it's really clear that, say, Asian and Africa in particular, their genetic makeup is quite different. And, schizophrenia probably has the best data so far in terms of variants that we know are not even found in Europeans that contribute to risk of schizophrenia. So we're totally blind to a lot of genetic variation. And that we need to know that variation because it's going to inform what we think causes OCD and how we might treat it. Like medication development, I mean, we're only looking at 20% of the pie. That's not good.
And when it comes to like treating it, Eric, you mentioned precision medicine. What is precision medicine? And I guess kind of I've always wondered, like, what's the likelihood that at some point we'd have like a really good, like, oh, you have this genetic makeup, let's prescribe you this medication. Or is it not that simple at all?
Yeah, well, I mean, so many thoughts on this one. So one of the first thoughts in relation to kind of the last, well, let's start with precision medicine. It's really about having an understanding of sort of the mechanisms at play that underlie a particular problem, and using that to be able to really have a more precise intervention based on characteristics of that individual. So right now, our interventions are sort of broad in a sense. Now, if someone comes in with OCD and we, recognize that they have a certain level of severity, let's say it's a high severity. What we're really doing is saying, well, we know that exposure and response prevention is a really good treatment. We know that antidepressants are a really good treatment. We don't really know which antidepressant. So we base it on a few factors like clinical experience. Maybe your parent took a certain antidepressant and did well, so we'll do that. Exposure therapy, we look at, well, you're motivated or have good insight, or you don't have good insight, and so we try to kind of gauge our intervention based on all these patient characteristics. So that's sort of what we're trying to get at here, is understanding how an individual's genetic makeup can help us prescribe a particular intervention. Now, two things I'll say and then I'll shut up. One is that broadly speaking, when John and I really started working in OCD space a while ago, the basic stuff that really, he was a leader in, and I sort of, hung on his coattails because I'm a lot younger than he is, was, essentially like efficacy stuff. Does ERP work better than nothing? Does ERP, intensively work better than ERP, weekly? And so the field sort of started there. And right now it's much more sophisticated in what we're doing. Like a study we have right now in kids is, if we have a kid on an antidepressant, can we treat them to remission? And then withdraw their antidepressant. Blair Simpson and Edna Foa did a great study that suggested that may be possible for some people. That's really exciting. So the field has come a long ways. And then in the case of, and Jim may be able to, talk about this much better than I can, but like with the BRCA gene for breast cancer, that's a perfect example of understanding someone's genetic makeup may predispose them for risk of a particular outcome that then allows you to determine your treatment regimen based on is this a elevated risk where you need a mastectomy? Is this just a risk where you need to follow more regularly, or you don't really need to worry too much about it? But that's a perfect example of this application here. And our hope is in psych, we can get there.
And like, what, just because Jim mentioned how like polygenic these things are, like, is there like a time course, or like, is it likely that we could get there where we'd have like a genetic makeup that we're targeting and have medication for that genetic makeup for that psychiatric disorder?
I say yes. I can think of two ways that I hope in my lifetime genetics will impact OCD treatment. And, I have a PhD in pharmacology, so I'm thinking more about medication here. But one is happening right now, which is pharmacogenetics. So there are companies that sell tests that, we hope give some prediction about how you might respond to SSRIs, for example. A lot of them are based on metabolism, like how your liver handles a drug. But that could also influence, how you respond to the drug. A lot of work to be done. There's bigger trials that need to be done for that. The jury is still out a little bit, but I think that will improve. That's number one. Number two would be like influencing drug development. And this is happening, say, in schizophrenia and bipolar, where companies are using the genetic results to actually, figure out what targets to go after. I mean, that is great, because drug development in psychiatry is really not almost non-existent. I mean, so they need new ideas, and genetics could be one way to do that.
So as it pertains to this study, or John, do you have a question? Sorry, I don't want to step on your toes.
Oh no, I'm just listening. I guess I would have. I'm going to play a little devil's advocate because we got to have some fun.
I knew it.
So when we say OCD is polygenic, or that it's a genetic, there's a genetic basis. What exactly is genetic about OCD? Like, so like in breast cancer, like we understand like how genes kind of lead to breast cancer, and things like Tay-Sachs disease, some of these other things. We know what the impact of like in trisomy 21, in Down syndrome. In OCD, what is it exactly that's genetic? Genes code for proteins. What do we know about the relationship between those genes, those proteins, and OCD?
Yeah, I think this is confusing to a lot of people, because for those disorders you mentioned, Tay-Sachs, some forms of breast cancer, they're like monogenic is the word, one gene. And those are really, I would say, easier to understand. Disorders like OCD are generally polygenic, which to me is more about probability. Like, to me, there's more of a bell curve of OCD type behaviors. And if you're on the far end of it, you might get an OCD diagnosis. But many people have a lot of these traits just in general. So to me, the genetics of OCD are about, if you have a really high burden, genetic or environmental, actually, you might be shifted towards that end of the curve. So it's a lot less clear. You can't point to particular exact proteins yet, really, but we can identify biological pathways and things of that sort that might be more, druggable. So yeah, unfortunately it's a fuzzier explanation than a single gene disorder. Those are much easier to explain.
Because I think like a lot of people have this idea, oh yeah, OCD is genetic, like eye color, right? Or like some of these other problems that we've been talking about. And I think it is important, for our people, the folks tuning in, that it doesn't work like that.
Not at all. Not at all. I mean, the genetic studies, one of the main findings is that it's not all genes. It's about half genes. So, these really important studies from Sweden, mostly twin studies and family studies, show that environment is just as important. And there's variation in that, of course, what you're exposed to and all kinds of things.
So do you, from this perspective, do you look at OCD as being, what's the word I'm looking for? Like binary, like either you've got it or you don't? Does a genetic, so talk a little bit about that. What's this polygenic perspective on OCD as a continuum?
Yeah, it's a complicated word, but most people use the term liability threshold. So that's a fancy word for saying that if you get a lot of bad stuff, you might be moved in one direction. So I think of that as like, maybe you have a...
Oh, we have to be calling my lawyer or something, liability.
So you might say have a genetic predisposition to have some reaction to, some infection. So there's a combination where you need some, genetic background, and you need exposure to some microbes, say, to have an effect. That's called like a gene environment interaction.
Mm-hmm.
So those two things combined might push you to that one end of the bell curve, which might make you, have higher OCD traits, but maybe you won't be, maybe you won't meet criteria for diagnoses. So unfortunately, it's fuzzy like that. Well, it's kind of unfortunate, but it's also, I guess, maybe a good thing. But anyway, it's not a great explanation, I don't think.
Yeah, but I think, Jim, in part what you're also saying, and I was probably really inarticulate in describing it earlier. I think that it's, while there might be some fuzzy aspects, we're more clear than we were 10 years ago. And even if we think of circuitry as, sort of a parallel thing, I think our appreciation of neurocircuitry in some ways, in many ways, has actually helped us understand stuff, especially when we're doing things like deep brain stimulation on the very, very few patients that would qualify for it. It gives us an area of, where to target, but an understanding of why it might operate. 20 years ago, it was sort of like, well, we think this circuitry is implicated and we're disrupting it. Now it's kind of a different appreciation of that. And so some of the neurostim that's not invasive, that's based on that, is really based on that theory of trying to target the areas implicated. So it's like the field's moving forward and discovering things at a pace that I think is different than before. And
yeah, certainly true in genetics. I mean, technology was limiting for many, many years. So we were only able to look at, say, 5 genes at a time. Now we just sequence the entire genome, look at all 20,000 genes. So technology has really helped. I agree. It's moving in the right direction. Not as fast as a lot of people would hope, but we're making progress.
To continue a little devil's advocacy, and then I'll get back on the Latino Project specifically. Like, Eric, when you mentioned circuits, do we have like a sense of like, oh, this is an OCD circuit, or are there just kind of like general anxiety circuits and fear circuits that come together in some strange way to make OCD, but could also end up making another psychiatric disorder put together differently?
Yeah, I think across all this stuff, Jim was talking about sort of the polygenic nature of psych conditions, and the reality is that it's not precise right now, and so a lot of the gene hits across, let's say, anxiety disorders are similar to OCD, and part of that is that a bunch of old dudes in a room made the first DSM. And then they didn't talk to your DNA, like there wasn't a Zoom, shortly after that. Here's what you should map onto. So it's an imprecise piece, and anyone who has OCD knows that anxiety is a core feature to this. I mean, this was an argument John and I made in one of the nerdiest papers we've ever written in 2008 about why OCD has such a robust anxiety element that you have to consider in its conceptualization. So I think these disorders, these problems, really operate in like a Venn diagram with lots of significant overlap. In terms of how it presents, how we think about it from a behavioral standpoint, which is how I think about it, but also a genetic piece, and circuitry piece as well. Same time, OCD's always been a little bit different, in some ways. I do think sometimes the differences have been overstated. That's just my opinion. Like anxiety or distress is a core element for virtually everyone with OCD, whether it's that it doesn't feel right. Not that I'm afraid of something bad happening, but it's feel right. Still distress that's motivating it. And I think that behavioral relationship operates the exact same as someone who has social phobia. I'm scared. I stay away from the thing, that the social situation that makes me scared, and I feel better afterwards. I do it more and more. So bottom line is, I think there's some unique aspects of OCD that come into play. There's some shared with other problems. And some of this sort of it helps us understand both the disease kind of makeup to it, but hopefully we'll also validate some of the interventions that we're trying or make them more precise.
So to kind of get back to the Latino Project specifically, Jim, what are we looking for with all the genetic data you're collecting? Like, what kinds of genetic data are you collecting, and what do you plan to do with it?
Yeah, so our hope is to sequence the entire genome, like I said, to look at all 20,000 genes. There's a little bit of funding uncertainty, so we'll either be doing that or something that's one step below that, which is called genotyping. Look at lower resolution. So to be determined, but the idea is either way, we'll look at every gene in the genome. And to do that, we get saliva. So all we need is a participant to spit in a tube, and I can get DNA out of that and sequence it. So lower burden. Back in the day, you had to do blood draws, and it was quite annoying. You needed dry ice, and thankfully none of that is needed anymore. You can mail these spit kits through the mail at room temperature. So our life is a lot easier than it was like 10 years ago.
And what kind of what outcomes are you looking at? Like SNPs, if you want to explain what that is, or?
Yeah. So there are, I guess, two major forms of, differences between, say, two people. SNPs are single nucleotide polymorphisms. So it's a change in one letter. So the genetic code is made up of A, T, G, C. So I might have an A, you might have a T in one particular position. And then, these are often like common variation, like many of us differ at the same exact position. And then there's also rare variation, which generally might even be private to you. You might have a variant that no one else in the world has. That does happen, or that we've sequenced. Sorry. Yeah, those are the types of variation we're looking at.
Okay. And then just kind of like more technical stuff, like who is included in the study? Like, how could they get involved? How can they send you samples? Do I just like email you?
Or maybe Eric, you want to take that one?
Yeah. Well, we have a fancy QR code, which is, Jim, is right next to your head on this one. But
Oh, sorry.
That's perfect. Essentially, so I do a fair bit of research. Jim, John, Kyle. We'll get you into the Cool Kids Club at some point. But this is one of the two studies that, frankly, I'm most passionate about, and so I'll describe it this way. I'm not a geneticist. Jim and I have a buddy that said, "Hey, I got a buddy who's really awesome, and you should meet him." And and said the same thing to Jim, and then we meet, and then we write a grant. We still hadn't met yet, and then we get the grant, and then we still hadn't met, and it's awesome, right? But here's the part that's so exciting. It's all the reasons stated for the science behind the genetics. But there's this other piece to it, which is this notion of addressing a health disparity. And then it's also this idea of, okay, well, how do we teach Bolivian therapists how to do exposure and response prevention or ACT? I saw Matt made a comment exactly about how with these core components, you can live a great life. He's absolutely correct. But guess what? If you're in Colombia and you don't have access to that, you're going to live with OCD most likely, unless you're lucky to be one of the relatively small number who can remit from antidepressants, which have reasonably good dissemination, but still imperfect because of the stigma. Mm-hmm. Last week, some of our colleagues that I've been working with for a decade now had a paper published on the front page of the main newspaper in El Salvador, and then a corresponding news story about OCD. There's never been a story about OCD in the news in El Salvador ever. So like this impact is huge. Mm-hmm. Now to your question, Kyle, of how can people get involved? It's easy. So you click the QR code. It took me a year to understand how to do that until my son said, click this button on your phone twice and then aim it and it automatically opens. So that's how you do it. I felt like an idiot. And then from there you put in a little bit of info, and then we schedule you for a Zoom interview. We mail out a saliva kit that looks like this, and you spit a couple times in it. You follow the directions on it, put it back in the stamped envelope, and it comes right back to us. It's de-identified, so no one can ever know that Joe Smith provided their DNA. And it helps you and helps your future children. That's, I think, the important thing to it. The other part that's really important too is, you don't need to be all Latino. And we'll talk a little bit about what we mean by that and Latin American. So if you have a grandparent that is, from the Caribbean, from Mexico, from El Salvador, that's terrific. That counts. Everyone these days is mixed, and it's really sort of a beautiful thing about our world when you look at migration patterns. But if there's anyone from your background who hails from a Latin American country, great, that counts. And we include places like Mexico and South of Mexico, and Central and South America, but also within the Caribbean too. And of course, if you live in Canada, the US, and so on, as well.
And kind of to the point of maybe differences in OCD, are there differences in like the subtypes of OCD that you see most often in Hispanic communities, or is there any difference in the disorder's manifestation?
Good question.
Kyle, brilliant question. we have no idea. No, it is. We have no idea, but we'll be able to answer this. And we just had our PI meeting, which, if you can imagine, like every time we have this, I feel this sort of, I don't know, just my heart smile, because you have literally 14 countries represented. You'll have 50, 60 investigators on this. And we're doing stuff like talking about, a training, on behavioral therapy, or we're doing a conference in Argentina where we'll, have a community event for folks with OCD, as well as professional events teaching, ACT and exposure therapy, pharmacotherapy, and so on. So like all this stuff is really impactful. But what we said, to your question, is that, from this, we're going to generate massive advances in not only the genetics of OCD, but how we understand things like, does OCD look the same in Bolivia as it does in Ecuador? For one, both in kids and adults. Are all the questionnaires that we sort of take for granted that work, in the U.S., well, do they work for people who are Latino? I'll give you an example of how that can matter. Do you know that a lot of old depression questionnaires would ask about crying? And guess what? That actually made women look more depressed than men, because women were more likely than men to cry, whether it's a sadness cry or just, like I'm really happy, or I watched, Steel Magnolias and cry. Not that I do, because much tougher than that. But like all of a sudden it over pathologized because the measure didn't work the same for women as it did for men. These are the exact same types of things that we'll be able to answer on an assessment or phenomenology standpoint.
And when you kind of meet with PIs from all over the world, how do they talk about like their own culture's understanding of OCD, and how does, like, from your perspective, how does it seem to differ from maybe how me and John would think about OCD?
My take on it is that the core elements of OCD are really, really similar, but there are a few key elements that come up. One of them is the role of family, and both in a positive, supportive sense, but also in a, how do you talk about this with other people around you? I think stigma is a second issue that's really pretty significant. I think healthcare access is a third big issue to highlight.
So as far as the presentation, right? Because we know, like, for example, like it can be influenced by religion and culture and things like that. Do you guys? That's a really great, interesting topic. Do you guys see that it's playing out differently in the Latino folks of the Latino background as opposed to, let's say, in the United States or Europe?
Mm-hmm. Yeah. I think it's early, but yes, we're seeing some things. For example, relationships that people have with, this is just one example, with individuals who's deceased. If you didn't understand the culture behind it, it may look like it's something pathological, sort of in kind of a delusional, psychotic sense, when it's not. It's very much a beautiful thing in a relationship with a deceased loved one where you're connecting with them in a very healthy fashion. But if we took very, American centric, Caucasian centric attitudes, you would totally like mischaracterize that. It's just one example.
That's really interesting. And again, gets back to the kind of just the nature of how we make these kinds of diagnoses. Right, based on it's so influenced by culture. In our culture, certain beliefs, you would say, oh yeah, that's OCD, or that's even element of delusion or psychosis. But then in a different country, that would be a completely, normative kind of belief that we wouldn't make any sort of psychiatric diagnosis based on. I find that stuff really fascinating.
Yeah, and that's what we'll be able, in part, be able to really answer this. And without this study and this opportunity to collect genetic data and address that issue, we won't know a lot of these questions. But at the end of the day, we'll have 5,000 folks, hopefully a few of them, in the chat right now, who will spit in a tube, but share kind of their experiences so that we're able to get more information about this in order to help the next generation of folks that are struggling with OCD.
Yeah, I just wanted to mention also that you don't need a diagnosis now to participate. You know, we have a screener in the very beginning if you end up going to the website. So, you know, one of the things about this project that really excites me is it's going to help people, you know, get into treatment, you know, people that aren't in treatment. So it might be the first research study I'm involved in that actually will help people directly. So it's one thing that really excites me. A lot of the research is quite basic, and you wonder if it's ever going to help people. So that to me is really exciting.
I kind of on that point, I was wondering, like, what are the treatment options in Latin America if you have OCD? Like, let's say you can overcome the stigma and you talk about it with someone. Are there like a lot of clinics? Are there a lot of physicians who are trained to help out with this?
No, I think it's not a good situation. And countries vary. So there are really some, there's some brilliant experts who are scattered about Latin America, but not in the numbers that you would need. And it's the same in the U.S., although I think it's much more problematic. So, you know, Mexico, there are a number of outstanding folks that are practicing, you know, whether it's private or within a you know, university type setting. But in general, I think what you see is that the number of people with expertise in OCD doesn't match even close to the population needs. I think there's an understanding and recognition of evidence-based interventions, but a lot of times those interventions just haven't gone down there. So I mentioned El Salvador as one example. My publisher of books that no one reads except my parents, and then that's even debatable. My
mom read them.
Yeah, maybe the ones that John's an author on. But like, you know, they I remember we were having a conversation. They're like, we just can't afford this book for $50. I mean, that's like a significant chunk of change. And so I had just sent them the PDFs, which is where my publisher would get fired up. But that's a real issue, or the language is a real issue. Even stuff like, you know, how do you translate some of these measures into, you know, Spanish or Portuguese as another factor. And, you know, I saw someone mention in the comment chat, I mean, Jim and I's next project is to try to convince NIH to give us a lot of money to investigate this in Asian countries. And, you know, in South America, you have Portuguese and Spanish. You know, here, we're talking about multiple languages that we have to translate the Y box into. But it's not the effort that's so salient. It's the fact that now there will be a Thai version of the Y box that we can assess OCD in. And with that, we can capture it and we can start building with intervention opportunities. That's, I think, what's also very exciting about Latino.
Is there any reason to think that there's differences in like the rates of OCD between cultures?
What do you think, Joe?
From a genetic standpoint, no, but I bet culturally, yes, in terms of like people that reach out and get treatment or that seek treatment. I could imagine in some environmental factors that might be more prevalent in different countries, but in terms of genetics, I wouldn't think so.
I think the data suggests that cross nationally, it's fairly similar.
Yeah.
Yeah, I would think it's just a matter of kind of overcoming stigma. Do you get
right?
Do you get a sense of like how stigma is, or like kind of what concerns are of people in Latin American countries about talking about their OCD? I know there's plenty of it in the United States, but I've never been to Colombia or Ecuador or anything like that.
Yeah, I think it's how one's perceived. You know, for men especially, it's a notion. There's a potential that's perceived as, you know, being weak or not able to, you know, kind of control something. I think there's concern similar to the U.S. Of misunderstanding about what these symptoms mean, as opposed to being a very real, you know, kind of mental illness. I think there's also a notion of, I don't know how to say this, like there's less hope. And so there's nothing like talking to a parent or an individual and they describe their symptoms. You're like, yeah, we know exactly what that is and what to do to help you. And I think that's one of the challenges that happens quite a bit south of our border is if it does come out, there's really not significant clarity of what it is or how to help.
Mm-hmm.
We once did a study of diagnosis or diagnostic accuracy in the Latin American providers, and it was the findings mirrored the U.S. So this is not a U.S. is doing great, Canada's doing great, everyone's doing poorly. But if you asked, psychologists, psychiatrists, pediatricians, PCP providers, and LATAM, that what you ended up seeing about all the subtypes is that people are pretty good at recognizing contamination or symmetry and ordering, and were abysmal at anything besides that, which is a massive percentage of our folks. So like, again, more room there, but if we're getting on the front page of the Salvadorian newspaper, like that's huge.
Yeah,
and that's what's happening across the way. The Chilean president has OCD, and there was a whole host of articles that went out. And then in a week, we'll do a series of talks down there, oriented to the professional community, but also to the people affected themselves. So again, it's getting the word out, talking about it, and every aspect of this sort of helps, make this, A, kind of something that we just talk about more, but B, it really puts kind of, pressures on for, let's start implementing these interventions.
Okay, two streams of thought came up. So like when you look at other psychiatric disorders in like non-European cultures, are there differences in rates, or is everything pretty stable? Not just OCD.
That's a good question. I really don't know. Maybe John or Eric could comment, but when folks have really done the real surveys of the population, I think that's when you really find maybe the true numbers. But those that actually get a diagnosis, I think, could vary really widely.
Well, and I think that some of it goes back to, like what I was saying before, the subjectivity of it. And Eric mentioned that the DSM was created by, a bunch of white guys in America. And so, we can look at certain beliefs that people would have here and evaluate them as being, let's say, delusional. But then you go to, other countries, and those might fit right in with, or other cultures, and those might fit right in with cultural norms. And so it's does that person have schizophrenia? Well, if they came to America and we didn't know anything about their culture and we just kind of applied the DSM standards, yes, we would say they do, but do they really have it in their own culture? No, I would say no. So I think it makes it really difficult to impose and this is more for some disorders than for others, but it makes it difficult to imply what we think of as a psychiatric disorder in the US and in Europe, and apply that worldwide. Because some of those disorders don't make sense in other cultures.
I mean, you guys are all in higher ed. Like, how do you feel like clinical psychology programs or maybe psychiatry programs talk about this and like hammer home that the DSM is made by a bunch of white dudes in America, and you have to be very sensitive to different cultures when making a diagnosis?
We teach in our program. I actually teach the class on psychopathology, and up until recently, the DSM didn't really say much about that. Now, if you read the DSM, those first couple of chapters before they get to all the disorders, but the introduction and all that, they do talk about that. In fact, the DSM actually says, we don't have a good definition of what a psychiatric disorder even is, or what mental illness even is. The DSM is even saying that before they go on and try to define what those are. But yes, we absolutely need to teach this, because that's, we're just starting to recognize how subjective all of this is and how culturally relevant it is. The newer DSMs have a section on cultural bound syndromes. There's a disorder that occurs in some Asian populations where you have a fear that your genitals are shrinking into your body. Men have the fear that their penis is shrinking into their body. We don't see that in other cultures. We don't see that in America. So no one gets a diagnosis of, I'm forgetting the name of that. Someone could look it up maybe. But in Asian cultures, you see that's a thing. That's a thing that people worry about. Just like, having OCD or social phobia or panic attacks or PTSD. So it really is. That's something that I'm fascinated by. Our program is very tied into kind of culture and multiculturalism, and I think that it's I think it's fascinating.
Mm-hmm.
I was forced to read those first couple chapters of the DSM, and my favorite part of it was like, it basically says like all the diagnoses in this book are like placeholders until we find like the biological underpinnings of all these things, which always seems strange to me because I don't know if I believe that there is like a certain biological root of OCD. Although, Jim, maybe you have a different perspective.
I think it's all about probability and, again, that liability threshold model to me makes a lot of sense. I mean, you can see it in traits like height. Take 50 guys and have them line up by height, inch by inch. It'll make a bell curve. Some of those people on the ends, are probably there because of genetics and environment.
Mm-hmm.
So, unfortunately, it's complicated, but that's the way it is, in my opinion. I think there is something biological. I mean, we can see it in twin studies. Why do identical twins, why does OCD co-occur in them much higher than it does in fraternal twins? When you look at, huge numbers of twins, why is that? It has to be DNA. I mean, they share an environment.
Mm-hmm.
Well, I don't know. I think if you talk to identical twins versus fraternal twins, they will tell you that the environment, growing up with an identical twin is different than growing up with a fraternal twin. A lot of people look at that twin research and they I think quickly conclude that those studies suggest, that it's genetic. I don't think it's that straightforward. And there is a literature on the limitations of those kinds of studies.
I'd love to read more about it. Nothing is really absolute in genetics, unless you're studying something monogenic, but I bet there is some aspect of that to it, but I'd be shocked if there isn't some DNA involved. Yeah. But I'd love to read about that. I haven't read the critiques of that literature.
The DSM-5, so DSM-4 came out in 94, and immediately groups were formed to start to think about DSM-5. And the goal was to have DSM-5 completely different and have it based on biology and genetics. So at one point, the anxiety disorders were going to be the fear circuitry disorders. I remember having a conversation with Daryl Regier, who was one of the framers of the DSM-5, fear circuitry disorders. And they kept kind of pushing back, at one point, DSMs usually come out every 7 to 10 years, right? And at one point, so DSM-4 comes out in 1994. So at one point, early 2000s, DSM-5, they kept kind of pushing it back. Finally, it comes out in 2013, right? And it's basically the same thing as DSM-4.
I was going to say, do we learn enough new stuff?
Well, and that's the thing. There is not one biological marker for a single, and this isn't good or bad, it's a fact. There's not one biological marker for a single psychiatric diagnosis. You can't take someone's blood or image their brain or look at their genes or anything and say, oh, based on this biological test, you've got this disorder versus that disorder, or this disorder versus not a disorder. Maybe we'll get there someday. We've got to follow the data.
In some cases, we're there now. So in autism, if you see developmental delay, in a 1-year-old, I think standard of care is to do a genetic test. And so, but again, that's kind of a case where there might be a single gene explanation for it. It's rare, but it does happen.
So can you take, let's say, 1,000? Can you take 1,000 people with autism and 1,000 people without autism and identify them based on their genetics?
There's absolutely some individuals, rare, a small number that will say have a mutation in a gene called CHD8.
Right.
They're going to have autism or something on that spectrum.
That's interesting. I didn't realize that was.
Relatively new research, but that is, like I said, standard of care from my understanding.
So if we, if we at some point can get to the data on these things, the
problem is it's not going to explain everything. It's always fuzzy with genetics of complex trait, and it always will be. Yeah. Everyone wants that single gene explanation, but it's only going to happen for some people. That's just the bottom line. So
I would appreciate it if you could find a Jim.
Trying.
Not to put pressure on you or anything. I wanted to ask both of you, like, let's say at the end of this study, how are you guys going to disseminate this information to the communities that need to hear about it?
Well, I know what I'm going to do. I'm going to partially retire. Really? I was hanging out with Jim. I'm going to move to Chapel Hill. I'm going to go to Lake Atlan in Guatemala and start smoking a pipe and then write 1,000 papers from these data. And then we publish like crazy. But no, I'm half joking. Jim knows that it's really half joking. Like that's my idea of the next chapter of my career after all this. I think that's one method of doing it. I think there's a broader method, and this has been something I've been very grateful to Jim for introducing me to, is really sort of this beauty of team science. And years ago, I would always kind of wonder, like, why does this paper have 800 authors? And I came to realize, like, how much work goes into efforts like this to bring everyone together and sort of moving in a collective direction that one group or two groups or 10 groups can't do, but you need a lot of people together on that. And so, I think these data will have the potential to stand on their own as I'm smoking my pipe and writing, from a lakeside manner. But I also think that it's in collaboration with others. And Jim, do you think it'd be helpful maybe talk about the relationship with the PGC? And
yeah, absolutely. So with genetic results, it's really important to share. Like I said, it takes thousands and thousands of individuals to participate to find anything. That's why genetics has been so slow, in psychiatry to make findings. We haven't had the number of people and we haven't had the technology, but finally we have both. But yeah, we share data. It's become the norm in genetics that
What's the PGC?
Oh, sorry. The PGC stands for the Psychiatric Genomics Consortia.
Okay.
So this is actually founded by someone here at UNC, but the big idea is share your data. Don't go off in a hole and do your little study that has no power. Work together to find something that is actually going to be reliable. And
don't pull an early career Eric and just stay only in your office and not talk to anybody.
That wasn't me. I'm pretty social.
Yeah,
I'm like a social butterfly.
When we walk around the IOCDF meeting, I could not believe how many people came up and said, "Hey, Eric." I mean, literally, you could not walk 5 feet without seeing somebody that you knew.
Yep, even John Abramowitz said hi to me.
I do. I'm a fanboy.
But I'm a fanboy of you. I'm in the front row of your concerts.
Let's have a big hug. And and I should say, it's kind of my job to be a little curmudgeonly. I'm the college.
Oh, I like it, John. Yeah, I mean,
thinking. I think what you guys are doing is awesome, and I hope the data are the data. So if anyone's going to do it right, I guess it would be you guys. So it'd be, it's great that you guys have the methods that you're using, getting huge samples, and hopefully it's going to tell us something to move our field forward. Because like you're saying, we don't have that much right now.
Mm-hmm. Yeah, I can totally understand the frustration and almost like disbelief in the genetics, because for it, so much has been promised and so little has been, found. And a lot of money and time has gone into this. That's probably taken away from psychological research. So, but I think we're finally making progress.
That's great.
They should have just given all that money to me. I did also, because we didn't talk about this too much, Eric, at the very beginning, you mentioned that like you're training a lot of clinicians in Hispanic countries, and that doesn't seem like related to genetics at all. So where did that come from? Is that part of this project too?
Yeah, well, so NIH gave us funding to, conduct these genetic analyses, so collect the samples, get their spit, do it. But what Jim and I really wanted to do was build on top of this. So it's really hard to describe how much time went into building this consortium, from meetings, cultivating relationships, some of which already existed. But what happened is I emailed John, and John's like, well, I got this buddy Kyle. And then we talked to Kyle for an hour. And then Kyle's like, but I got this buddy Jim. And then we talked to Jim for an hour. And so we put this group together, and it's still happening on that. But we really wanted to take this infrastructure that we spent developing and building this really close cohort of investigators to say, how do we address this disparities issue? How do we start, getting more providers in Peru who do exposure therapy? And I don't at all want to imply this is, my or Jim, effort alone. We have so many engaged collaborators, and it'd be remiss to name, name one or two or three of them, because everyone's really has their heart and soul into this project, because it is about that notion of paying attention to a group that hasn't received attention that it should receive, both from a genetic standpoint, but also an intervention standpoint. And we're really fortunate to have these groups, this group of colleagues, and other stakeholders like, Alex, who's on the call, has been critical in teaching Jim and I, who are archaic and have no social media knowledge, like how to get the word out, how to do it appropriately, and we've had other groups as well in that same space. So it's really, this team effort that's pushing stuff forward, that really is trying to address a critically important topic in the OCD field.
Yeah, I mean, you can even use a QR code.
And QR code, right? I mean, it's huge.
That was a very good answer, but I am a little bit disappointed to know that I still have to network, even if I go into science. Networking is just terrible.
Networking it takes a lot of effort. And the problem with Zoom is, like, back in the day, I'd be like, John, can I meet you? Yes. And then we'd have a beer. It's like, if you have a beer over Zoom, it's just frowned upon. So, a little bit harder that way too. But no, everyone has the same mission, which is, making a difference in OCD, whether it's for genetics, whether it's for treatment, psychotherapy, pharmacotherapy, or so on. And I think, when we look back on the last 2 years, it's been pretty impactful what we've been able to hit on, and excited for the next several.
Oh yeah, it's been going on for 2 years. I didn't know that.
Yeah, I know. Now, mind you, a year was spent getting it up and running. And when we looked at recruitment today, what we've actually seen is we've got about 10% of our sample collected. So it means a lot of other people whose spit we need. But the pace
it's probably
of
a nicer way to say that.
yeah, I know. DNA we need, but yeah, I mean, it's like a train moving out of the station. It starts slow, and now it's really chugging along beautifully.
Well, I mean, I hope some people on this live stream who are either on an hour or going to watch it later can help out. There is a link that Amanda, you could put up to click along with the QR code. I mean, you can go to the Baylor College of Medicine website and just type in Latino study on Google, honestly, and it'll come up. There's an article about it on the ICDF that you can go ahead and read. And I encourage you guys all to help out Eric and Jim, because they're pretty cool people.
Thank you. Thanks for the opportunity. Really appreciate it, Kyle and John.
Yeah, ditto.
And everyone that helped with this.
Yeah, thanks for everyone for tuning in. This is one of many live streams. So go to the icdf.org/peace of mind to see the entire schedule of future streams if you want to check out any more. And yeah, thanks for joining.
Thanks, guys.
All right. Take care, y'all.